This lecture will have two parts. First of all, I think it's useful to understand the nature of hypnosis, to understand where it came from historically. And then, secondly, I'd like to talk about some evidence about the clinical usefulness of hypnosis. So we can trace a history and prehistory of hypnosis that goes back to spirit possession. I'll talk a bit about that later, which I regard as the same phenomenon as hypnosis, and probably its more natural or frequent expression. And that particular way of expressing hypnotic behaviors is still with us today, and we see it in spirit possession, but also in other practices like esoteric martial arts, as in the clip that I showed at the end of last lecture. Now, there's a particular historical strand that ends in what we now call hypnosis. It starts with hysteria. It crossovers a bit with spirit possession. They'll take us into animal magnetism and hypnosis. And what's common to all of these phenomena is, we can say, the power of belief and expectation that results in an altered sense of volition and of reality. So let's turn to hysteria. Hysteria, well, that comes from the Greek word for womb. So that's sort of the literal meaning of the word, which is highly misleading, just as the name hypnosis is misleading, because hypnosis means sleep. It goes back about 2,000 years. We now don't call it hysteria, the phenomenon that was called hysteria. We call it maybe conversion disorder or somatic symptom disorder, depending on the particular system of diagnosis that we're using. So in DSM, standard American system, it's somatic symptom disorder. What hysteria involves is symptoms that look like they should have some organic cause. You'd naturally expect them to have some cause, as in the nervous system not working properly because of damage. For example, blindness, deafness, paralysis. But no cause can be established, and the symptoms might be such that it seems an organic cause is unlikely. So, for example, a person might feel numb in an area that corresponds to an area that will be covered by a glove, but there's no nervous pathways that deal with specifically and only that area. The original theory of hysteria, going back to the Egyptians and the Greeks, was it was to do with the womb. It was a wandering room theory. So the womb was wandering about the woman's body. This was causing the symptoms, and the reason why it was wandering was that the woman needed to get pregnant. So one of the solutions or attempted cures of this was prayer. So we, for example, have this 10th century prayer: O Lord, stop the womb of thy maid Rebecca and heal its affliction, for it is moving violently. I conjure thee, O womb, in the name of the Holy Trinity, to come back to the place where the Lord has put thee originally. And sometimes this worked, and sometimes it didn't. In fact, something like a wandering womb and theory extended right up to the 19th century, at least in the version of it was maybe the woman needed to get pregnant, maybe she didn't have enough orgasms. So you had doctors in Britain and the US in the 19th century masturbating women to orgasm in order to cure them of hysteria. And that was why vibrators were originally invented in the late 19th century, was for medical practice. Well, just stepping back to the 15th century, it was sometimes hard to, at least in the eyes of the people at the time, to distinguish hysteria from demonic possession, because they'd have very similar symptoms, namely something physical, organic, happening without a medical cause being able to be established. So we have here a report from Benny Vieni, father of pathological anatomy, who says, "A new and extraordinary disease is nowadays rife, which I scarcely dare to describe. A girl broke into terrible screaming, and her belly swelled up at the spot. She flung herself about from side to side, and sometimes touching her neck with the soles of her feet, would spring to her feet. I concluded that it arose from the ascent of the womb," so he has a hysteria theory, "but I found the normal treatment for this of no avail. I decided she was possessed by an evil spirit, and she was handed over to physicians of the soul." In other words, priests who would engage in exorcisms. So exorcisms were fairly common practice as we come into the 18th century. And there was one priest, Gassner, who was going around demonstrating the benefits of exorcism, that when recited the appropriate prayers, the woman would go into convulsions and then feel a lot better afterwards. Well, the German Mesmer, who's the founder of Mesmerism, who observed this, decided that there was a more natural explanation, an explanation more in line with the physical sciences. And he'd been studying the use of magnets for the treatment of disease with Father Maximilian Hell. Hell was a priest and an astronomer. In fact, one of the craters on the moon is named after Father Hell. Well, what Mesmer learnt from Hell was that passing magnets over people could be therapeutic. And in his first patient, Franziska Oesterlein, she had convulsive symptoms. So normally you might say this was hysteria, or maybe it was demonic possession. What Mesmer thought it was the magnetic fluids flowing around the body not flowing properly, getting blocked, getting stuck. And what you needed to do was to get the body's natural magnetic flows working smoothly again. And indeed, when he applied magnets to her body, she would convulse in the location the magnets were applied and then feel better. So Mesmer argued that the people like Gassner conducting exorcisms, they were sincere in their beliefs, but they were mistaken about the mechanism. The mechanism was one that could be explained by magnetism. And magnetism was all the rage at the time, in terms of the physical sciences, understanding what magnets were doing. So we know if you pass a magnet over your body, or over the body of a person with conversion disorder or somatoform disorder, you don't get convulsions. So why did Mesmer's patients convulse, including the very first one, Oesterlein? Well, she was probably aware of the convulsions that happened in exorcisms, and that was her model of appropriate behavior in this newer therapeutic environment, which she took probably to, well, this is a therapy, there's this other therapy, and what you do is convulse. That was her belief. She was probably sincere in that belief. And so that's what happened. Now, when Mesmer originally used magnet, but he thought there's no need to use magnets, because if the human body has magnetic fields and magnetic flux, he could use his hands, and so he developed a practice of passing his hands over the bodies of his clients not touching them, but just moving over the surface to channel his magnetic energy, magnetic fields into his patients. Now, once one person had convulsed, and this became a famous case study, everybody knew what you do is you convulse. So Mesmer moved from Austria to Paris, where he set up his practice, and you can see here he could help magnify his magnetic powers by having a tub here full of, say, iron filings and water and other things, and he would have rods he could use to wave over people. And his clients would come in, and he would approach, he would wave his hands, they would hold batons and connected to the tub here, and then they would go into a crisis, which are these convulsions. They would shake all over and would feel much gratified by the experience and feel a lot better, and would often come back again and again to experience the magnetic convulsions. Well, Marie Antoinette was very interested in this, and there was a lot of gossip around, particularly in the court of King Louis, and he was a bit concerned about the moral implications of this. And it wasn't just moral implications in the sense of a sexual sense, well, that was part of it, of women being thrown into crisis by this man and apparently enjoying it a lot, but also the political implications of a person being able to have control over a mob of people. And this was regarded as rather dangerous. So a royal commission was set up that included some very famous scientists like Lavoisier, the founder of modern-day chemistry, Benjamin Franklin, who was over in Paris at the time, Joseph Guillotine, who invented the guillotine, although it hadn't been used against royalty quite at this time. And they decided to set up some experiments which were one of the first controlled set of experiments in psychology. It wasn't quite the first. In fact, there was another Royal Commission in 1599 investigating the effect of religious artifacts on people. And they used a similar procedure whereby, for example, Latin was recited and the person hearing it was told it was religious scripture, and they would feel relieved from their illness. In fact, it was the poetry of Virgil. So the procedure was, that double-blind procedure was picked up by Franklin's commission here. So they do things like, well, I didn't tell you, but what you could do is you could magnetize trees, and you could magnetize cups of water, and a person who touched the tree or the water would get the magnetic fluid and be sent into convulsion. So what the commission did, they couldn't convince Mesmer himself to come, but a true believer and disciple of Mesmer did come along to help them. They'd magnetize one tree and not another, and they would tell one of the clients of Mesmer the opposite thing. So one man who was particularly sensitive to going to crisis was told that this tree had been mesmerized. In fact, it hadn't at all. As soon as he touched it, he passed out, was completely unconscious, and had to be carried out of the garden. Now, previously, he had touched another tree that had been mesmerized, but he told that it hadn't been, and it had absolutely no effect on him. And they did the same with magnetized water in what nowadays we call a crossover design, where you actually mesmerize one cup and not another, but you can tell people something different. And what they found was, what mattered was not the object that had been actually mesmerized, but what people believed. As long as they believed it had been mesmerised, that was good enough, regardless of whether it had been mesmerised or not. So the commissioners concluded that effects of magnetism were due to imagination and belief. And this is actually a very important conclusion, and a potentially very powerful conclusion for medicine with a lot of positive repercussions. But the tone and intent of the Commission's report was to say, and therefore it's a load of rubbish. So therefore we can dismiss this mesmerism nonsense, and it in effect should not be practiced. Well, this was a bit unfortunate, because as a disciple of Mesmer said, if medicine of the imagination is the most efficient, why should we not make use of it? So this debunked Mesmer's particular theory that it was anything to do with magnetism, but it didn't actually debunk the phenomenon. But the debunking of the mechanism got confused with the phenomenon, and it was just regarded mesmerism had been debunked. So Mesmer's popularity went into decline, but it didn't mean that everybody stopped practicing it. So the Marquis de Puysegur carried on practicing mesmerism, but he had always disliked the idea of crisis anyway, of going into convulsion. He mesmerized peasants on his estate. These peasants, not being part of high society, they didn't know what you meant to do when you were mesmerized. And the Marquis wouldn't be himself giving any cues that the appropriate response was crisis. So one day, one of the first peasants he mesmerized, Victor Race, as the hand motions were made over him, he didn't go into crisis. He apparently fell asleep. He didn't really fall asleep, because he was responsive to the suggestions and instructions of the Marquis. We don't know why he fell asleep. Maybe it was something the Marquis implied. Or maybe it was just an idea, just as Mesmer's first patient had an idea that she should go into convulsions because of past experience she'd had with witnessing and experiencing exorcisms. Maybe Victor Race, just some association in his mind, some random thought he had, thought, what's appropriate is I should be in a sleep-like trance. So because of that one idea that someone had, this little historical accident has now been frozen in time, and from then on people had the notion the appropriate thing to do is to fall asleep, and what mesmerism or later hypnosis was about was sleep. And that idea is still with us today. But as I said in a previous lecture, hypnosis has absolutely nothing to do with sleep, and you don't need to make people feel sleepy in any way. In fact, they can be rather alert and still just as responsive to imaginative suggestions. And indeed, when James Braid, the Scottish physician, came across the phenomenon, he coined the term hypnosis, or neurohypnosis he used originally, as a sleep-like state brought about by fixation of the eyes, concentration, and concentrating on one idea. So he coined the term monoideism for the mechanism of hypnosis. And then he thought a process of neural inhibition took over, and that's where the sleep-like state came about. So now, if you were to tell someone they're hypnotized, like maybe you see on TV shows now, you hypnotize, people go like that, that's because they understand that what you are meant to do when given the suggestion that you're hypnotized is to act like you're asleep. And so we have a confusion between the essential nature of the phenomenon that we're talking about. I said before, maybe there's some special trance-like state, but that, whatever that state is, it's not sleep. We have the phenomenon of responsive suggestion, which is real, but whatever the mechanism of hypnotic response, it's got nothing to do with sleep. But sleep has become confused with the essential phenomenon itself. And we can see that throughout the history of hypnosis. So in 1900, around about 1900, if you hypnotized a highly hypnotizable person, you need not suggest amnesia, in other words, memory loss, for the events that happened during the hypnotic episode. The person would spontaneously lose memory for the events of the hypnotic episode. It did not need to be suggested because it was understood that hypnosis, was believed that the essential nature of hypnosis involved memory loss. But around about 1960, somewhere, obviously it wasn't a sharp cut-off, it was just gradual, you only got amnesia if it was specifically suggested, if you gave a post-hypnotic suggestion for amnesia. His beliefs had changed. That association of amnesia with hypnosis hasn't been completely eradicated. So often when I hypnotize people, I'm asked, will I lose memory for the events that happened? So people still have this idea that it's something to do with amnesia, but they're not sure whether they're meant to have amnesia or not. The belief doesn't have the conviction it did have 100 years ago, and so the phenomenon of amnesia doesn't really occur unless it's specifically suggested. I'm not sure if you remember the name Martin Orne. He was the person who coined the term demand characteristics and invented the real simulator design. He showed this phenomenon experimentally by giving a lecture on hypnosis. Well, he gave two lectures, one to one group of people, one to another group. To one group of people he said, when you're hypnotized, your right arm will spontaneously stick out like this, and if the hypnotist moves it anywhere, it will just stay like that. And that's part of the hypnotic state. So later, when they're hypnotized by another person, no suggestion for arm levitation had to happen, because it was now part of their beliefs that this is the nature of the hypnotic state. Those people who had received that lecture found when they were hypnotized their right arm stuck out. So beliefs about hypnosis became confused with the essential nature of it. So what we have as what we call hypnosis is just a particular cultural manifestation of a more general phenomenon, and our cultural manifestation of it has depended on particular historical events that have happened and leave their mark as in terms of our current beliefs about what hypnosis is and what you're meant to experience and behave when you're hypnotized. But if we take hypnosis to be more generally the phenomenon of doing things where it doesn't seem to you that you're doing them, imagining and perceiving things that aren't there, so having distortions in your sense of volition and reality, then we see that all over the world, all through history, in the form of spirit possession, and in religious contexts as well. And it's interesting to compare, as I did last lecture, esoteric martial arts, where we don't have any sleepiness involved, and those people doing backflips because the master projected his ki, there's no sleepiness involved, they're very alert, as I said last lecture, no induction was needed. Another example we see in current times is the state oracle of Tibet. So still, for the Tibetan government in exile, if there's a difficult decision of state to be made, they may bring out a monk whose job is to channel protect the deity, Peha Gualpo, and they'll put on an extremely heavy, you can see here, this is metal, I think it's about 70 pounds of costume. The monk will spontaneously dance about with this heavy costume. He's exerting a lot of effort, This is an intensely physical experience that he'll be having. And furthermore, he will not be passive in the sense he's been given a question to adjudicate on this important matter of state. So he'll then give advice. So he's not in a passive state of mind, either physically or mentally. And then he collapses. But if you ask the monk afterwards, was that you doing it? He'll say, no, I did not experience myself as giving that advice, as dancing. I was possessed by the protector deity. So this is the same phenomenon. He has experiences of his actions as happening not by him. They were not volitional, at least not his volitions. And he had deliberations, and he told people what to believe and think about important and difficult issues, but that was not him. It doesn't look like hypnosis, but that's just because there are different cultural expectations and beliefs involved. And this is just a holiday snap of me. This is the Neijang Temple at 3,800 meters near Lhasa, where the state oracle of Tibet resided before he fled with the Dalai Lama in 1959 with the Chinese invasion. Also consider talking in tongues in churches. People say the Holy Spirit overcame them, and they start babbling, and it doesn't seem to them that it's them doing it. Consider Ouija boards, where the glass moves around, and people do not experience that it's them doing it. Shamanism, possession by animal spirits, and so on and on. So in all of these phenomena, we need not doubt the sincerity of the people having the experiences, which is why it's so compelling to them. But exactly what happens depends on the cultural context. So when a shaman is overcome by an animal spirit, the experiences he has, the ways he behaves, are all appropriate to that culture. Because essentially, if hypnosis is about taking expectations and beliefs and somehow, through a process we have yet to completely understand, into experiences of non-volition and reality, you can convert whatever is culturally appropriate in that context into the experiences that strengthen, consolidate, and reinforce the religious, spiritual, or other beliefs in which that performance is taking part. And so by performance in these cases, as I want to keep saying, we need not believe these are fake or sham or particularly credulous people taking other people for a ride. These can be genuine experiences that all participants really believe in and experience. So, like the first lecture, I want to say hypnotic experiences are genuine in all of these contexts. They can be genuine. But the other thing that I've told you is you can't do anything hypnotically you couldn't do normally. It's just that it feels different. It feels involuntary. It feels like reality has changed. But if you put those two things together, what does that mean about clinical or applied applications? Well, if hypnosis is about changing your experiences, maybe hypnosis will be particularly useful in clinical contexts which are about changing experience. And one experience that you'll often want to change is pain. And indeed, hypnosis has proven clinical effectiveness in dealing with both chronic, in other words, long-lasting, acute, short episode pain. You can use it in childbirth, including with caesarean section. In other words, when you cut the woman open in order to take the baby out. In burns, headache, fibromyalgia is where people feel extensive pain, but no organic cause can be determined for it. Hypnosis can be useful. It is especially used in dental practice. I don't know why it's taken off especially there. Maybe that's just again, a historical accident that some dentists got particularly into it, and then a tradition emerged of dentistry using it. But imagine you go to the dentist. You can be injected with chemical analgesia, and the dentist gets out the drill and works away. It might be reassuring that you're pumped full of chemical analgesia, but what do you have for the rest of the day? You're slobbering and dribbling until the chemical analgesia wears off. So if hypnotic analgesia was useful for you, it would be especially useful because the dentist can spend about 10 minutes giving the hypnotic analgesia. Analgesia means pain relief. The hypnotic analgesia suggestion. Then get the drill out, work away. You feel little to no pain or anxiety. And then at the end of the procedure, your tongue isn't numb, you're not dribbling. You can go out and have perfectly normal and respectable conversations with people. So hypnosis in a clinical environment can be extremely useful. By the way, whenever it's used clinically, people are given the option of chemical analgesics. So you say, anytime you want, just tell me, we'll inject you with something chemical. But there are some people who don't need that, even for caesarean section. They use hypnosis as a sole form of analgesia. In fact, they'll come back again the next time they have caesarean section, or the next time they have even major orthodontal surgery, not just drilling a bit of tooth out, and have hypnosis as the sole form of analgesia. So that's very useful, but how does that square with what I said before, that you can't do anything with hypnosis that you couldn't do otherwise? Because I don't know how many of you think you could go to the dentist, just effectively chat to the dentist or hear the dentist say something for 10 minutes, and then have them get the drill out and work away on your mouth with no chemical analgesia. That might sound astonishing to you. Well, it turns out that your ability to reduce pain is far greater than you probably believe. So hypnosis isn't the only form of analgesia that's out there. There's also methods of pain control derived from cognitive behavioural therapy, CBT, which is the main form of therapy now used in the UK and many other places around the world. Stress inoculation training, derived from CBT, is also a completely psychological method for dealing with pain. So this study compared hypnotic suggestion with non-hypnotic suggestion. By that I mean cognitive behavioural therapy in a lab situation. So in the lab we can hurt people in various ways. One method we use is at Sussex, by we, is you put the person's arm in ice cold water, temperature maintained just marginally above 0 degrees. By a minute you'll be experiencing excruciating pain, but we know physiologically no damage will be done. A minute in ice cold water, you're not going to get gangrene. No damage is going to be done to your tissues. So in a very safe environment, a lot of pain can be produced without any harm being done to the person. There's a number of methods like that. Cold pressor pain, the one I just described. You can tie a tourniquet or band around an arm to restrict blood flow. Very rapidly, lactic acid builds up, and again, by a minute, the person can be in extreme pain, especially if you ask them to do something physical, like grip one of those squeezy things. Or, as in this study, thumb screws. You have a device that applies pressure to the thumbnail or fingernails, and you just ramp it up until you get a lot of pain. And you can see here how much pain you can give people. Let's say you say on a scale 0 means no pain at all, and 10 means pain as intense as you can imagine. So that's the scale, but you say it's open-ended. They can go above 10 if you want, but you define the scale to them beforehand. 10 is as intense as you can now imagine. Well, on average, people went up to 15. But with a hypnotic suggestion, that was halved on this scale. So, on average, considerable pain relief. And this is more for the highly hypnotizable people. So for the very highly hypnotizable people, that can come down to 0. So it can be highly effective. But what happens when you use CBT, this is not a significant difference, by the way, here. You get pretty much equivalent pain relief just by controlling the way you think, the things you think about, the things you say to yourself, what you imagine, how you attend. Just by giving some strategies along these lines, pain can be massively reduced. Now, is this because the non-hypnotic method is the same mechanism as the hypnotic method? Well, that's not shown by this study. They do produce equivalent pain relief, but that doesn't mean it's the same mechanism involved. For example, when people receive CBT, they'll tell you that they actively used various imaginative and attentional strategies. With hypnosis, the person can say, my mind was blank, I wasn't thinking or imagining anything. Just the pain went away by itself. Some people take that to mean a different mechanism. But it could just be, it's exactly the same mechanism involved. It's just as I said before, what hypnosis makes happen is that things happen by themselves. That's the experience you have when an action is performed hypnotically. Any old fool can raise their arm, but with a hypnotic suggestion, your arm will rise apparently by itself. So maybe here, highly hypnotizable people use strategies, but they're not aware of using strategies. It doesn't seem to them they're using strategies, so it seems to them the pain went away by itself. So it could be the same mechanism. But what would hypnosis add clinically? It adds the sense that the pain went away by itself, and that might be a more compelling or pleasant experience to think it wasn't you doing it, it was just the pain disappearing. Now, I should say, there is a debate. So what everyone is agreed on is that by giving suggestions non-hypnotically, you can reduce pain to at least the same degree as you can hypnotically. So you can get a massive reduction in pain by a number of methods. Some people argue that when you give a hypnotic induction, followed by suggestion, you get a small increase in the pain reduction. So this goes back to what I was talking about in the previous lecture, that without an induction and you give suggestions, you can get highly hypnotizable people to experience any suggestion that you want. When you add the induction, you add a small increase in effectiveness. But the question is, what does that mean? Does that mean that there's some different mechanism involved? Or does it just mean you've pumped up expectations and beliefs a little bit, and so you get a small increase in effectiveness? And indeed, what you can do in hypnotherapy, in other forms of hypnotherapy, other than analgesia or pain relief, you can deliver what's normally, in this context, normally CBT, but it doesn't have to be, cognitive behavioral therapy, as a treatment for, let's say, obesity, anxiety, hypertension, high blood pressure. But just tell the person that this is hypnosis, or you don't mention hypnosis. For example, in order to deal with phobias, one of the most effective methods is what we call systematic desensitization. Let's say you're afraid of spiders. We could get the person to imagine a little spider just at that entrance over there on the floor, and they start getting anxious. You say, now calm down. You relax them, calm them down until they're really relaxed and comfortable. You just get them to sit there, confront the spider over there just by the door, until they feel completely relaxed. And then you move it a little bit closer, maybe just in imagination, a little bit closer, a little bit closer, a little bit closer, getting them to relax each time, and you just up the ante each time until they're imagining spiders crawling all over them and they feel, yeah, I'm just chilling out here. And Also, you'd probably use real spiders as well and get real spiders crawling all over them. So that's systematic desensitization. You gradually increase things, at each point making sure the person's completely relaxed. Now, you can do this, especially initially in imagination, so it has a feel of a hypnotic-like procedure, but this procedure was developed completely outside of hypnosis. The hypnotherapists use it as well, and often it looks like exactly the same procedure, just that they call it hypnosis. In fact, you can arrange it so that it is exactly, the literal script is the same, except in one case you call it hypnosis, in the other case you don't. Irving Kirsch reviewed a number of studies looking at a range of conditions, comparing cognitive behavioral therapy either with or without hypnosis. And hypnosis fairly dramatically increased the effectiveness of the therapy. So this is one way of expressing that. The average client receiving therapy with hypnosis was better off than 75% of clients receiving the same therapy without hypnosis. So hypnosis enhanced the effectiveness of the therapy, even when I say the only difference was the label hypnosis. So I tend to think that if just calling it hypnosis increases the effectiveness, that's probably a fact of expectation and belief. Here's a particularly dramatic example. This was treatment for obesity. This is the degree of weight loss. And here what's especially striking is not only did the gains maintain themselves after therapy, they actually got bigger. So this is right at the end of therapy, the degree of weight loss, and we can see with hypnosis is a bit better without hypnosis. But by 2 years later, the with hypnosis group is considerably better than the no hypnosis group, by about 15 pounds. Now, some people say, what about giving up smoking? And indeed, there are a number of hypnotherapy packages out there for helping people give up smoking. So now, remember, hypnosis is just a sort of a tool. It's not a therapy in itself. It's not as if you say to people, and now you'll find you have stopped smoking, as a suggestion. No, you need to embed the hypnotic suggestions and the hypnotherapy part of it within a package, and most of the work goes into developing the exactly what you're going to do, the exact therapy. So you're going to imagine your lungs getting more and more tired up. You're going to imagine what are you going to do when you feel the craving, alternative things you're going to do, and so on. Well, the best way of determining the effectiveness of hypnotherapy will be by not just relying on verbal reports, but by taking a measure sometime, let's say 6 months afterwards, of the amount of nicotine actually in the person's system. So we're not relying on the person's report of whether they've given up or not. And if we look at reviews of a large number of studies, we can say hypnotherapy is effective. About a quarter to a third of people will be abstinent for 6 months, as determined by lack of nicotine in the system. So that's pretty good. It is actually about the same as many of the other procedures out there for helping people give up smoking. Probably has the advantage that it's quicker than other therapies, and that it can be done in 1 session, maybe 2 sessions, the standard practices for hypnotherapy for smoking cessation. But now, as I said, what you do in the hypnotherapy session is probably very similar to what you would do in many other therapies, like getting people to imagine the harmful effects of cigarette smoke, and in particular getting people to think about exactly what they're going to do in particular situations when they feel cravings or the situations in which they typically smoke. So is the effectiveness of the therapy anything to do with hypnosis? Or is it just that people are having a therapy that has some effectiveness? Also, they paid a lot of money, they made a lot of commitment to this. Are they going to waste this money and start puffing away a few weeks later? Well, one way of establishing this for hypnosis is seeing if the outcome is correlated with hypnotizability. And the outcome is not correlated with hypnotizability, at least if it is to only a very small extent. That suggests, and I'm sometimes reluctant to tell people this, that the hypnosis component of it probably isn't what's important. The reason why I'm reluctant to tell you is because of that previous research I just told you, that when you say to people that hypnosis is involved and hypnosis is powerful and enables us to contact your unconscious and so on, you increase the effectiveness of the therapy. But in this context, I just have to tell you truthfully what the research shows, and it seems to show that the hypnotic component is not what's important in these smoking cessation packages. Another context in which hypnosis is often used and is, I think, surprisingly effective is wart removal. So you can give a suggestion like, notice that the skin on and around the warts on your hand is beginning to feel warm and a little tingly. You can feel the tingling, prickling sensation around the warts, and you know this sensation will cause the warts on your hand to disappear. You can see the warts on your hand shrinking in size and dissolving away. Now that does, in fact, cause warts to go away at a greater rate than spontaneous remission. In other words, warts will tend to go away by themselves. This increases the rate at which that happens. And there's evidence that it's not just placebo. It's not. You need to give this sort of suggestion rather than just a pill and say your warts will go away. But it's the suggestion that's important. You don't need to give a hypnotic induction. Now, what I think is going on here is a number of phenomena have become caught under the label of hypnosis, and one of them is the effect of imagination on physiological processes. So, for example, by imagining my hand being warmer and hotter, I increase blood flow to the hand and it gets warmer and hotter. But that isn't necessarily the same phenomenon as my arm rising by itself. But I think that's a different phenomenon. So I think the effect of imagination, the direct effect of imagination on physiological processes is something else than what we imagine with our hypnosis screening processes. Very interesting, very useful, but a somewhat different phenomenon. So, to conclude, hypnosis can produce positive expectations and beliefs and make outcomes feel as if they happen more by itself. And those two things are clinically useful. I'll leave it open whether that effect they produce, because of the beliefs people have, is somehow some direct effect of the expectations or beliefs, or an effect that's not due to an altered state, but I leave it open that it could be due to an altered state that introduces a new mechanism of change. And I'll leave that open for you because that is still an active area of debate. So, next lecture we'll move on to another important applied aspect of hypnosis, and that is, what is the effect of hypnosis on memory? Can memory be improved by hypnotic suggestions that you can go back to the time of a crime, for example, and see what happened? That'll be one half of the lecture, and the other half will be consider the important question, clinically important, given hypnosis is clinically important, of why are some people more hypnotizable than others. Thank you very much.